relate to the difficulties we are having just staying sane in this pandemic, but for some groups in society, the impact is much more severe. And we're going to be examining today just what those impacts are, the numbers, the expertise. Nous allons regarder vraiment les grandes questions autour de la santé mentale et COVID-19 et les groupes qui sont affectés plus ou moins par cette pandémie. Pour ceux qui ne connaissent pas, mon nom est Tasha Keridine, je suis animatrice, écrivaine et membre très fière du réseau COVID-19. I'm a proud member of the Social Impacts, COVID-19 Social Impacts Network that's putting on this event. And for those who don't know what that's about, it's a multidisciplinary group of some of the country's leading experts who are helping identify key issues and impacts and socio-demographics that are addressing the economic and social impacts of COVID-19 in Canada. Le réseau COVID-19 sur les impacts sociaux rassemble un groupe multidisciplinaire d'experts du premier plan du pays pour s'adresser aux questions clés, les indicateurs sociodémographiques et les impacts de la crise COVID-19 au Canada. We'd like to thank the Social Science and Humanities Research Council for their generous support of this and all the COVID-19 Social Impact Networks conferences. We've had 3 more before this. We'll be having a couple more after as well. This conference is also being recorded. So if you missed part of it, don't worry. It will be available on various websites, including the networks after the fact. Merci beaucoup au Conseil de recherche en sciences humaines pour son généreux soutien de cette conférence. The conference is divided in 3 parts. We will be starting with 2 great speakers, and then we will have 2 great panels after that. All of the panels and speakers will be accepting questions. So please use the Q&A feature at the bottom of your screen, not the chat feature. S'il vous plaît, mettez vos questions dans la fonction Q&A et pas le chat, s'il vous plaît, pour tous les participants à l'événement. One last housekeeping measure, since this is an online conference, we ask that you please be really social about it. And the hashtags for it are social impacts COVID-19 and SSHRC_CRSH. S'il vous plaît, allez sur les réseaux sociaux et mettez ces hashtags en évidence. So let's go now to our first speaker. Anna Romano is the Vice President of the Health Promotion and Chronic Disease Prevention Branch at the Public Health Agency of Canada. She has over 25 years of experience providing strategic policy advice and recommendations to decision makers in the federal public service. Anna has had the opportunity to work in 10 federal organizations, including Treasury Board Secretariat and Agriculture Canada. Au cours des dernières années, elle a dirigé plusieurs initiatives transversales et mis en œuvre les principales priorités stratégiques fédérales, notamment l'introduction de nouvelles lois et stratégies nationales. Et dans son poste actuel, elle supervise les investissements, activités et partenariats qui soutiennent la recherche et la surveillance en santé publique. Welcome, please, Anna Romano.
Thanks very much. Merci pour l'occasion de participer à cette séance. Welcome, everyone. Thank you for that warm introduction. It's really an honor for me to share the opening with General Dallaire this morning. This is a great opportunity to participate and exchange our knowledge on this very important topic today. So from the perspective of the Public Health Agency of Canada, clearly the impact of the pandemic on the overall physical and mental health of Canadians has been significant. Everyone is facing unprecedented disruptions to daily life. Some have lost their jobs or are experiencing financial uncertainty. Others are feeling isolated from their family and friends. At the Public Health Agency, we have been very much seized as well with the unintended consequences of some of the public health measures that we've had to put in place, including increased family violence, problematic substance use, and reduced access to community supports. I'm sure that we'll hear from the experts that we've lined up for session 1, that what the surveys and other data points are telling us about our collective mental health. What is certain is that the pandemic has shone a light on long-standing inequalities in our society. COVID-19 has had a disproportionate impact on certain populations who may be less able to deal with its health, social, and economic impacts. As we address the mental health needs of all Canadians, we are looking carefully at the specific needs of these priority populations, like frontline and essential workers, seniors, and caregivers, to name a few. This also includes Canadians who might have limited ability to follow the public health guidance that has been provided, such as those living with low income, in overcrowded or unsafe housing, and people with disabilities. We are interested in tailoring our interventions to better meet their needs based on the best available evidence. At the Public Health Agency, as well as Health Canada, we have been taking a number of steps to help Canadians get the resources and tools that they need to take care of their mental health in these uncertain times. And I just would like to share a few examples with you. The first is the launch of the Wellness Together Canada Mental Health and Substance Use Support Portal. The resource is available to all Canadians, and it provides access to self-directed tools and credible information on mental health and substance use. It connects users to peer support workers, social workers, psychologists, and other professionals for confidential chat sessions, phone calls, and online counseling. And I'll be happy to leave the link to the portal in the chat box during this conference. Since the onset of the pandemic, I've also heard from a number of crisis lines. Their call volumes have spiked, not surprisingly. To help meet this increased demand, the government announced very recently funding to Kids Help Phone, and we're also providing additional funding to the Canada Suicide Prevention Service. Recognizing the unique needs and challenges faced by older adults during the COVID-19 pandemic, the government is also expanding the New Horizons for Seniors program to support organizations that offer community-based projects aimed at reducing isolation, improving quality of life for seniors, and helping them to maintain a social support network. It's for sure that mental health will continue to be a priority throughout the COVID-19 pandemic and beyond. Our actions need to be informed by the best available evidence. To that end, at the agency, we're working closely with partners such as Statistics Canada, the Canadian Institute for Health Information, and the Canadian Institutes of Health Research to produce the evidence needed to better understand the short and long-term effects of the COVID-19 pandemic on the overall health of Canadians. And we know that this evidence is continually evolving. This is why this forum today and others like it are critical to help guide our ongoing response to the pandemic and the actions we take as we move into the recovery phase. So thank you once again for hosting this important exchange today. I'm grateful for the opportunity. Je vous remercie encore une fois. I'm very glad to be here and happy to hear from the experts who will be participating in the conference. Thank you.
Thank you so much, Anna Romano. We will now be going to our next speaker. Anna already sort of introduced him. She mentioned, of course, as you know, General Romeo Dallaire, who is no stranger to anyone. I'll still give a bit of bio here because, you know, for context, but he is, of course, the founder of the Romeo Dallaire Child Soldiers Initiative, a global partnership with the mission to end the recruitment and use of child soldiers. He's a celebrated advocate for human rights, respected author, government, UN advisor, and former Canadian senator as well. Lieutenant General Romeo Dallaire has been awarded accolades including the Nelson Mandela Award for Human Rights, University of Victoria's Humanities Award, and the Adrienne Clarkson Prize for Global Citizenship. And of course, son intérêt dans la question de santé mentale est à la fois personnel et professionnel. Son expérience avec la crise et le génocide en Rwanda en 1994, quand il a demeuré sur place avec un petit groupe de troupes et d'observateurs, en dépit du demande de quitter la région. Il était là pour des raisons morales et éthiques et était témoin de grandes difficultés. In 2019, which was actually the 25th anniversary of the genocide in Rwanda, the government of Canada announced the establishment of Dallaire Center for Peace and Security. So I'm sure we're all very excited to hear his views on the subject of mental health and COVID-19. General Dallaire, to you.
Ma chère madame, merci beaucoup je suis particulièrement enchanté de l'opportunité de me joindre à vous aujourd'hui. Et dans le contexte que le scénario dans lequel on se retrouve n'est pas terminé, c'est-à-dire que on ne parle pas de quelque chose qui a passé et qu'on essaie de voir comment on a évolué pendant, mais au contraire, nous sommes en plein dedans. And so you find yourself in a scenario that is very similar, in fact, to those who find themselves in conflict zones, in which you've got an enemy out there, in which you have the uncertainty, you have the anxiety, you have the fear of becoming a victim at any moment's notice. You have an inability to necessarily resolve the situation. And on the contrary, you find yourself enormously restricted, and your ability even to be able to handle the situation is constrained because of the imposition, in this case, not martial law, of course, but the imposition of health restrictions that are imposed by the government and the different authorities, both medical and political. What I am capturing most during this time frame has been the effect that it's been having on two particular groups who are, in fact, in one case, more vulnerable than the other, but in the other case, prepared, really, to take a revolutionary stand in regards to combating, fighting, taking an offensive position in regards to handling this problematic that this COVID-19 has imposed upon us all, not only locally, but nationally, internationally, worldwide. And so the first group is those of my age. I'm 74, going on 74. The vulnerabilities from the medical side, of course, and that has created an atmosphere that has increased the anxiety. And although the anxiety can be identified by the fact that we're isolated, it is really the inability to communicate physically with loved ones, with the grandchildren, to be able to feel the warmth and the attention of those who are close to us. That is an extraordinary imposition on their ability to sustain the effort of walking through this pandemic and ultimately even defeating it. So the vulnerability of the elderly, not just by their locations, but by the nature of the beast that we're facing, has made them just that much more vulnerable. And that calls for a counteraction, in my opinion. And the counteraction, to me, would come from the youngest of generations. That is between the 18 and 30 to 35, the teenagers, those who are mastering the revolution of our time, which is the revolution of communication, the ability to be in real time with anybody in the world. And although you're physically not side by side, yes, you're restrained in your home, yes, it's causing enormous anxiety, you still have this incredible tool. What surprises is that group, that young group, seems to be suffering the most. The most of that distancing, of that inability to be with others. And so as my work with the Douglas Institute is evolving in regards to how we help families and individuals and those who are injured already come through this, it is my opinion that the instruments of communications are still not being maximized, that there is no way, no matter what group, can we come through this in isolation, truly, meaning isolation from all communications, simply listening to the newscasts and probably being depressed by them, but not having another human being, not having peer support, not having someone who calls you, someone who establishes that link of communications or that you are able to communicate with. And so in all the evolving scenarios, I believe that we're in, I'll use the term, a sort of war zone in which the enemy is still at our doors. We haven't defeated it, but we have a certain lull in the situation that still has uncertainty, and that we must be very attentive, all of us, to make sure that the enemy doesn't win. Secondly, there is no way that we can replace the physical communion between people as a overt system of automatically bringing back peace and serenity, because people will be affected by the time already we spent in isolation. The third, there is a screaming need for people to talk, not to feel isolated, not to be locked in, not to hide in the basement, but in fact to be called, to be spoken to by other human beings. And so I mandate the young generation who's hurting to call, to communicate with the older generations. Take on a mandate of actually being a peer supporter, of communicating with those that you know who are older than you, and demonstrating a resiliency that you will be able to overcome this, that you can, yes, manage it difficultly, but that you're gaining strength by communicating with those who need your support. Become a sort of communications first responder, and in so doing, assist in attenuating the impact of this isolation, of the restrictions, and give you a chance to sustain, still for a while, the imposition upon your life and the life of your family in order to ultimately combat this enemy, and that we can reestablish what that norm will be into the future. Thank you for listening.
Thank you so much for those wonderful words. A communications first responder is a great idea. I think that it's something that also might give a lot of hope to people, especially young people who feel they are powerless in this situation. I want to go to a couple of questions, one of which touches on exactly the technology piece that you just referenced. And it comes from an anonymous attendee. It says, what about the individuals without technologies? I guess to Anna, what is your team doing to help with that specifically? And to General Dallaire, what would you encourage in terms of more multi-diverse age groups and seniors perhaps and others who don't have access to technology? How can we bridge that divide? Who wants to start?
Sure, I can start. I'll be brief. We've certainly been working with our colleagues at Employment and Social Development Canada who have a lot of programming in the area of seniors and, you know, how do we guard against social isolation. And I know there's been a few ideas floating around with respect to that exact question of what about those seniors who don't necessarily have access to technology. I know my mother's 85 years old and she doesn't have an iPad or any kind of computer setup at home. So it's something that we are thinking about. And it kind of links back to my remarks around keeping in mind that not everyone is the same. We have to think of those vulnerable populations and tailor some of our interventions to take into account those that might not have access to the same things that that others in sort of more privileged positions might have. So it's a great question, and it is something we're thinking about.
Okay. General Dallaire, qu'est-ce que vous direz à ça? Comment, s'il y a un problème avec la technologie ou un manque de technologie, comment est-ce qu'on peut trouver une façon de faire un pont entre ces générations?
Ben moi, je vais vous conter une histoire que je pense guide ce que ma réponse va être. Ma mère était hollandaise, a vécu 5 ans de guerre. Ils ont vécu être confinés dans leur maison pendant 50 ans. Sinon, les nazis les tuaient. Ça fait qu'ils ont survécu ce scénario qui est très difficile, un état de guerre. Puis après ça, elle est venue au Canada. Et ça a pris 18 ans avant que mon père, qui était dans l'armée, avait beaucoup d'argent, avant qu'elle puisse retourner en Hollande visiter sa famille. Donc, on a toute cette période de manque de communication. Et le téléphone, à ce moment-là, coûtait une fortune. Je pense que c'était 5 piastres pour 1 minute ou quelque chose comme ça, qu'on entendait à peine. Mes chers amis, Tout le monde a un téléphone. Tu sais, retourne à la vieille, je ne dis pas de retourner à un téléphone rotatif, là, mais le téléphone. Et beaucoup des gens de mon âge, on est souvent plus à l'aise à communiquer avec un téléphone sans qu'on nous voie, et ainsi de suite, et qu'on puisse donner le ton de notre conversation d'une façon quasiment plus pure, c'est-à-dire sans la visualité, on l'imagine. Et donc, moi, je dis, prenez le téléphone et appelez. Pas les harceler nécessairement, mais appelez les gens. Et ils vont répondre. C'est surprenant comment ma mère a été dans un CHSLD pendant un nombre d'années. Elle a épouvantablement souffert et ultimement elle est décédée. Mais c'était le téléphone qui était son lien avec le monde extérieur à ce moment-là. Et moi, je dis, faites-le, téléphonez. Puis, dans ce contexte-là, la conversation, écoutez. Pas parler beaucoup, écoutez. Laissez-les parler. Soyez le sage à les écouter, dire qu'est-ce qui les traumatise, qu'est-ce qui les fait vibrer, qu'est-ce qui les ennuie, et répondez nécessairement, mais donnez-leur l'opportunité de vider leur sac, vider la tension et le stress qu'ils ont par cette communication humaine avec vous.
Okay, merci beaucoup. I've got a question. I'm going to ask each of you one more question. And I've got one here that is for Anna. Anna, from an anonymous attendee, says, how can Anna help with the neurodiverse youth who are not limited youth with mental health challenges, but who are on the autism spectrum, Down syndrome, for example, and the hard of hearing? How are you going to collect data and make change for this community when it is often neglected?
Well, that's a great question. So certainly one area we've been looking into is the issue of disaggregated data and making sure that we collect data that is reflective of the general population. But then in addition to that, are there subpopulations that we need to zero in on to see how we can tailor our interventions? So that would include, you know, the obvious of the sex and gender-based kind of disaggregation, but also race-based data that would look into, as the question suggests, those with intellectual disabilities. So we work very closely at the federal level with provinces and territories, with our colleagues at Statistics Canada, as I mentioned. And I think this issue of disaggregated data is one that it's been in the media a lot, and it's certainly something that we are really focused on and trying to gather as much of that information as possible so that we can tailor those interventions appropriately.
Great, thank you. Et dernière question, celle-ci pour Roméo Dallaire. From Darlene McLeod, I'll read it in English, and I'd love to have your personal take on what keeps you going as well in terms of combating social isolation. But she asks, how can the stress of social isolation and the anger over social inequities be tempered for positive social change and action versus mental despair? Comment est-ce qu'on peut retourner ça pour combattre l'anxiété mentale et trouver une façon de trouver de l'espoir, selon vous?
Vous savez, moi, je pense qu'il y a un groupe qui pourrait nous donner beaucoup d'informations sur justement comment tourner un scénario si négatif à quelque chose qui pourrait être une expérience positive. C'est-à-dire que on est en train de se battre dans cette situation si difficile pour que, ultimement, cette expérience-là va nous aider si jamais on se retrouve dans un scénario semblable dans le futur. Donc, l'idée, c'est de bâtir de l'expérience pour mieux se prendre soin et être prêt pour la prochaine fois. Puis ceux qui ont vraiment cette attitude et cette capacité de faire ça sont les vétérans et leurs familles. Parce qu'on a au-dessus de 600 000 vétérans au Canada. Et ajouter leur famille, c'est beaucoup au-delà de 10 000 personnes. Et les familles vivent l'isolement de leurs proches. eux, en opération, ont vécu ça. Il y en a plusieurs qui ont été blessés aussi, tant psychologiquement que physiquement, et certainement des enfants et des familles, des membres de famille de ces gens-là ont subi des fois même des traumatismes à cause de ce qui est arrivé à leurs proches en opération. Les vétérans savent comment tourner un scénario qui a été si difficile, si restreignant et qui a eu énormément de stress, on peut vous dire, et même les traumatismes, et évoluer avec ça. C'est-à-dire voir qu'il y a une possibilité de positif dans le futur et d'avoir, and I'll say it in English, they see hope. They don't lose hope. And in fact, they nurture hope by the experiences of having already gone through, in many cases, hell, and seeing that there can be a day after that. And it's the building of the hope for the future and acquiring that experience of working through this. And so I say, call on the veterans and call on their background, and they're all over the place in order to let them give that expression of how they're handling it. I'm handling it by being part of the Douglas Institute and their campaign, being part of this conference, of keeping myself busy in my world of child soldiers, and the wars still are ongoing, children are still suffering. We're trying to prevent that. Find the cause that's beyond your house and look at that cause and put efforts into it. Find a cause. And it can be long-term, short-term, but find something outside of the house that you can give yourself to by the isolation, but through various means. That will shift gears, and that, I believe, will be very positive.
Thank you so much. Merci beaucoup, Général Dallaire, pour ces mots d'inspiration. And thank you so much, Anna, for all the helpful information and for the hope also that we have that people are really paying attention to this issue at all levels of government. And we will get the data we need to also make a difference. So merci beaucoup à vous deux. Thank you. We're now going to move on to our first panel of the conference. And here to introduce them, pleased to welcome Jennifer Kadatz. She is Senior Advisor of the Vanier Institute with the family. She will be presiding the panel and introducing the members of the panel as well.
Thank you, Tasha. Very honored to be here today. We have such an illustrious panel to talk about some evidence-based data that we have on mental health in Canada. We'll be beginning our session today with Julie Bernier, who's the Director of Health Analysis Division at Statistics Canada, and she's also the Senior Scientific Editor on Health Reports. Following her, we're going to hear from Dr. Norbert Smits, who's with the Douglas Mental Health Institute, and Dr. Paul Hawley, who is the Research Director at ACS Metropolis. Closing out our three-speaker session, we will have Jack Jedwab, who is, of course, the President and CEO of ACS Metropolis. So I could give a lot more detail on the qualifications of all these people, but I'm sure that you'll all trust and learn from their presentations that they really are the experts on these topics. So Julie, if I can pass the microphone to you now, I think we'd all love to hear your presentation on Statistics Canada's data.
Thank you for inviting me. So as mentioned by Jennifer, I'm heading a group at Statistics Canada that is doing health analysis. So we tend to have a priority that varies over time, and we for sure didn't see that one coming. So we had to shift our work very fast to a new era. So I'm going to give you a presentation today. I hope I'm full screen, about what Statistics Canada is doing and what information we're collecting at the moment, and to support decision-making and to support the people who have to decide on where they're going with that crisis. So Statistics Canada as a modern center for population health data, we have data coming from different directions. We have a lot of information on substance use, physical activity, sedentary time, smoking, nutrition that come either from our survey or survey that we have with real measurement on the field. We also are the host of birth mortality and hospital data, and that are more administrative type data. We look at the data with a lens on poverty, housing, education, employment, which has also social determinant on which STAT can collect a lot of information. And we also put the lens of equity on what we do. So we're well equipped to measure information on a lot of area. Unfortunately, we were not, over the last couple of years, measuring a lot of information on infectious disease. And we had to move pretty fast, and we decided to embark on that journey with FACT. We're giving them support on their measurement of or surveillance of infectious disease. But at the same time, Statistics Canada wanted to provide different policymakers with information of the social impact of some of the decisions that are made, such as the lockdown and shutting down activity on a lot of industry, and shutting down the school, and a lot of the social measures that have been taken lately. So how are we measuring the mental health of Canadians during COVID-19? We're going different route. So we have the survey that we're usually doing, the Canadian Community Health Survey, that have a lot of information on mental health. Every 4 years, we do a focus survey on mental health. Unfortunately, it was like 3 years ago. We also have a process to do rapid response survey program. And those are tools that we regularly use to measure a topic that come to attention. And we also, as I mentioned, are the host of a lot of administrative data. We needed to adapt very fast the health statistic program and other social program to provide timely response to the support information need during the COVID crisis. So we decided to create a new tool, a new survey tool that is called Impact of COVID-19 on Canadian. It's what we call the crowdsourcing tool. It's a little survey, not so long, 5 minutes, that happen on our website, that people are invited to go and report or answer questions. And we're having different iteration, and we're changing the set of questions on a regular basis with a lot of respondents. But this is not a tool that has a full design survey plan. So it is additional information. It's not the typical information that StatCan will use, but it was the most rapid way to gather information. So there were a first iteration where we measure information on impact of COVID on Canadian, including some health information, some social concern. The result from that data gathering was released on April 23rd. The second iteration, we put some of the focus on mental health impact, including anxiety and stress. And we also ask a lot of questions about the way people are changing their behavior, both positive and negative. So we ask questions about the method that people are taking to improve their health, such as communication with family and friends, outside exercise, meditation. But we're also asking questions on alcohol, tobacco, and cannabis use. We also launched a real survey that is the Canadian Perspective Survey Series. It's what we call a web panel. So we use a panel that are mainly LFS respondents that were invited to answer a new series of questions in top of the LFS labor force survey, question. The first wave was really similar to what was on the crowdsource. So health impact, self-rated mental health and physical health, and change in substance use. That was also released early April, so at the very beginning of the crisis. The second wave was focusing on mental health impact, including, again, self-rated mental health, anxiety, and question about trouble with relaxing, trouble sleeping, worry, stress, being more irritable. That one was released June 2nd, and both those products are, both the crowdsourcing and the Canadian Perspective Survey are those are first wave, but there are more waves that were collected in May and June, and it will continue in July. The vital stat information is also there too. We used to receive mortality data 6 to 8 months after the end of a year because of some treatment that need to be done by the coroner office and by the province to make sure that they use similar standard. In this specific case, because there were a lot of interest for excess death, we had an agreement with the provinces that we will receive provisional data on a I would say near to real-time format that we also make available on our website. All those products that we collect, the data are made available on a public use format, so researcher can access those data if they want to use them. It's all available from our website. So commitment to moving forward. We want to be responsive to user need. We want to engage partner. We engaging a lot of partner in the choice of question that we put on those survey. The first couple of waves had a lot of question on impact of financial situation, ability for people to telework, and some of that information was used to decide to put in place a program to give monetary subsidies to people who had lost their job. We also do a good job of integrating data. We're investing in leading edge method. We have a lot of focus on micro simulation and modeling. And as I mentioned, we use that expertise to support the public health agency. And we also have a lot of expertise in geospatial and innovating tool for people to look at information at a more granular level. So a geospatial analysis tool has also been released on our website. And for new information is coming on that geospatial tool every second week. We have some of our output that are meant for more user-friendly audience. We do data visualization, infographic, storyline, but as well as we have tools that are meant to serve researcher, such as all the data that you can download from the website. So information that we have measured up to now on a very fast and rapid way on mental health. So I will give high-level result because it's really brand new data that not a lot of time have been spent integrating with other information or other data holding. So first, to mention, the self-perceived mental health of Canadians have dropped during the beginning of the COVID period. So people who have who self-report that they have excellent to very good mental health are 54% of the Canadian, when typically over the last couple of years, when we're measuring it in the annual Canadian Community Health Survey, it tends to be 68 to 70%. Women are particularly impaired, like they are more around 50% that rate their mental health as being very good or excellent. Also, a question was asked for people about if they perceive a decrease in their mental health. And again, there's a lot of people who say that their health is decreasing, 50% actually, on the first week where we collected information online. On the second, 1 month later, when we collect again that information, the number had changed a little bit, but not to the point that it's a big difference. But it seems like people perceive a loss of their mental health, but it's a self-perceive. It's not diagnosed or any specific symptom. For the crowdsourcing, again, half of the participants report that it has worsened with the physical distancing. So people who say that it's about the same are around 40%. People who say that it's somewhat worse are around 45%. And people who said that it's much more worse now are around 10%. to give you an idea of how many respondents we have, the first wave of the crowdsourcing attract 250,000 respondents. Some of the infographic that we have created that are on our website to inform people. We ask Canadians if they have symptoms that are consistent with moderate to severe anxiety in the previous 2 weeks, and 18% of the Canadians qualify by the answer as having symptoms, 15% for men, 21% for women, and it varies by age group. It seems to be worse for the younger group, the 15 to 24, and it's a group that is less at risk of getting the disease, but as mentioned earlier by General Dallaire, it's a group that feel really impaired by not being in contact with their relative. But also it's worth mentioning that when people were asked about what they mainly think about or what prevent them from being quiet or sleeping well, in the youth age category, their main concern is the health of their relative, especially their parents and their grandparents. So they worry for the elderly. So Canadians that were classified in the my mental health is worse than it was before. We look at how likely they were to have increased some bad behavior. So actually, they are more likely to have increased their cannabis consumption as opposed to the one who don't see a difference in their mental health. They are also more likely to have increased their alcohol consumption, and there's no big difference in the tobacco area. Youth are more likely to report worsening mental health, as I mentioned. So here's a full description by age group. The slide will be circulated, I think, after. I don't want to go into that level of detail. And the majority of youth are engaging in positive health behavior, such as communicating with their friend, very high, like around 94% of them, doing exercise, around 65% of them, either indoor or outdoor. They are changing their food choice, 40% of them. It's in big part due to the fact that they can no longer eat outside, but still it's a good outcome. And a certain percentage of them are using medication or other relaxing technique. So what is next around mental health and COVID? Because this is a really high-level overview of how people feel and how they adapt to the situation. There's not a lot of detail provided there. So the next thing that we want to look at is what's the mental health of healthcare and other frontline worker, which we think it's a really important concern. Also, what's the mental health for vulnerable population? So how could we disaggregated to look at immigrant, indigenous people, and people that were, even before the crisis start, financially vulnerable. What will be the change in mental health over time as we settle into a new normal? And also, what's the mental health of families, especially the one with young children, and how they are coping with the new situation? Thank you.
Merci beaucoup, Julie. C'était vraiment intéressant. We will hold questions for Julie until the end of the panel, at which time we'll be having questions for all panelists together. But as a reminder to put your questions for the panelists in the Q&A section. We are now going to hear from Dr. Norbert Schmitz, who is with the Douglas Mental Health University Institute and a professor in the Department of Psychiatry and an associate member in the Department of Epidemiology and Biostatistics at McGill University. That is a long title. And as well, Dr. Paul Hawley, who is the research director at ACS Metropolis and a regular contributor and member of the Social Impacts Network.
Thank you very much for your introduction. So it's a great pleasure to be here on this panel. And I would like to present some results from a study we did in Quebec. So I hope my slides can be seen. Okay, so I would like to talk very briefly in the first part about depressive symptoms during COVID-19. presenting some results from Quebec. Here our focus was on depressive symptoms, on clinical depressive symptoms, to see. We were not interested in if someone has been diagnosed with depression or if the general feeling that people might be depressed. So we were interested using a clinical tool to see what is the level of depressive symptoms during COVID-19. So we had two aims in mind. One was to quantify the prevalence of depressive symptoms in a community sample of adults in Quebec, and to get a better understanding, so to evaluate associations between depressive symptoms and fear of contracting COVID-19 or fear of economic problems caused by the pandemic. So we decided to use a clinical questionnaire, the patient health questionnaire. So this is a questionnaire that's now used for more than 15 years, and it's used in thousands of studies around the world. So there's a lot of evidence about the performance of the questionnaire and about the validity. It's a brief questionnaire with 9 items, but those questions focus on a major depressive episode, which is laid out in the DSM and ICD categories. So it has some key symptoms like little interest or pleasure in doing things, feeling down, depressed, hopeless, and additional symptoms covered here. So for the study, we had to do a small modification. We decided to use the PHQ-8. So we dropped the last question about suicidal thoughts in the past, because we were not in place to offer support if someone responded positive to this item. So this is one limitation, but the PHQ-8 has been widely used, similar to the PHQ-9. So how it works is we compute summary scores, summing up individual items, and a score of 5 to 9 is usually considered as mild depressive symptoms, and the score between 10 and above is considered as moderate to severe depressive symptoms. So PHQ is a screening instrument for major depression. So when we use this instrument, we get some ideas about symptoms in the past 2 weeks, but it gives us some idea about major depressive disorder. So there are a lot of results showing scores above 10 have sensitivity, specificity of about between 80 and 90% for major depression. So the survey was conducted in the first week of May with 1,600 people from Quebec using the Leo online panel. And we here present weighted data. So we use the data from the census to weight for sociodemographic characteristics. So then we're interested in comparing our results. So we used data from the Canadian Community Health Survey in 2015-16 to compare the prevalence of depressive symptoms. So the PHQ was used for the first time, I think, in 2015-16 CCHS. But one drawback here is CCHS PHQ was only used not in all provinces, so it was not used in Quebec, it was used in some of the other provinces. So to have some more data from Quebec for comparison, because there might be difference between provinces, so we compared our results with data from the Cartagena study, a population-based survey in Quebec, at least for the middle-aged adults. So what did we find? So when we look at our classification at moderate severe depressive symptoms, so we have a prevalence of 19 in our sample, which is much higher compared to the CCHS, which would be 6.8% for the PHQ-9. And when we compare men and women, so we see a high prevalence of symptoms in men and a high prevalence of depressive symptoms in women. So moderate to severe depressive symptoms are 3.5 times higher in men and 2.5 times higher in women compared to the CCHS. And what is really striking, and what was mentioned before, so we see a very high prevalence in young people, age group 18 to 24. So it's again 3.5 times higher in younger people compared to what we would expect based on data from the CCHS. We see increased level for the other age groups, but really striking the difference for the young people. For the elderly people, it's less elevated, but we have to be careful. Probably we have some kind of U-shaped relationship. Some people are doing, elderly people doing really well, but there's a high risk group of people with chronic conditions like diabetes, cancer, who might have a much higher level. So there might be some kind of U-shaped associations. So when we look at a language, so there was not a big difference, English and French, similar difference as we would see in the CCHS. And yeah, marital status and all the other sociodemographic status, we see a very similar pattern. So what we would expect for depressive symptoms. So like here, single have a much higher prevalence compared to married participants. And we see the same association in general population surveys. But what is really different is the high level of symptoms. Not so much the pattern, but the high level of depressive symptoms. And as expected, prevalence of depressive symptoms much higher in the Montreal region compared to Quebec City, and other Quebec regions were somewhere in between. So as I said before, we're using here two different tools. We use the PHQ-8 compared to the PHQ-9 in the CCHS. So might be that there's some methodological differences. And one question is, do we have a wrong comparison group? So Quebec was not included in the CCHS group. So we decided to do some comparison with the Cartagena. Cartagena survey in Quebec, which was conducted between 2008 and 2014 and is still ongoing. So baseline was in 2008 to 2014. Community sample of middle-aged adults aged 40 to 69 years. So we have 40,000 participants from urban areas. And so first, when we look at comparing PHQ-8 to PHQ-9, so we see for Cartagena, if you use the PHQ-8 score, we have 2.9 and PHQ-9 3.0. So it's not a big difference because usually this suicidal items is not endorsed very often. So when we compare our sample with the Cartagena sample, so we have a mean of 4.9 compared to 2.9. To translate into effect size, so we see an effect size of 0.5, which is really substantial in a population-based survey. And when we look at the, again, at the moderate severe depressive symptoms, so we see in our sample it's 18% compared to 4.5%. This means we have 4 times higher prevalence of depressive symptoms compared to the general population aged 45 to 65 based on the Cartagena data. So when we look again at individual symptoms, what is really striking is we see the key symptoms of depression have a very high prevalence. So people reporting losing interest or pleasure in doing things, feeling down, depressed, hopeless. So there's a big difference of a factor 3.5, 3.7 compared to Cartagena. All the other items like poor appetite or feeling low energy, for sure they're high prevalence too, but the key depressive symptoms, it's really striking there are important differences compared to the time before COVID. So in the last step, we were interested, how can we explain this? What are different factors? And fear might be an important factor associated with this increased level of depressive symptoms. So we did some regression analysis and we see a strong association between fear, that people are personally afraid of contracting the virus, and job loss permanently and loss of some pay, some income, also associated with depressive symptoms, even after adjusting for age, sex, and sociodemographic characteristics. So what is the summary here? So we see a high prevalence of depressive symptoms during COVID-19, 3 to 4 times higher compared to population samples before COVID-19, high prevalence of depressive symptoms in young people, young adults, and depressive symptoms associated with fear of contracting virus and fear of permanent job loss. I think important strategy is to monitor mental health. There might be a peak now during COVID, but it probably will not go back to the level before. So chronic stress, chronic depressive symptom might be a very important issue here in this context. Yeah, and I will stop here and we'll hand over to Paul, who provides some more broader perspective on this topic.
Thank you, Dr. Schmitz. I'm really glad you went first as well, because there was a fire alarm that just went off in my building right as you were starting, so that would have been bad timing. So I'm going to just pick up basically where Dr. Schmidt's left off, and whereas his study really focused on the Quebec sample, we also did the same study on a national basis. So I'm just going to highlight some of the findings that we found from that study. You've already seen this, but the study was done about a month ago at the beginning of May. And Dr. Smith's already talked about the actual questionnaire, but you can see it's based on 8 questions. And the scale ranges from 0 to 24. So we'll start from there. So this is the national sample, again, compared to previous CCHS data. And we find here, there's generally the same pattern as we found before. It's just much more amplified in terms of moderate to severe depressive symptoms and mild symptoms. They're all very much higher than they were in previous studies, but the same general pattern you'll see. So females, 27.5% of females are showing moderate to severe depressive symptoms across Canada. And what we'll find here is that actually Quebec's depression, even though it's much higher than usual, is actually lower than the rest of Canada. So you also see here for the age groups 18 to 24, 42% across Canada as of early May were showing moderate to severe depressive symptoms. Again, the same pattern from CCHS data in the past. What I will show is that the 25 to 34 group, you can see it's almost 5 times higher than it would normally be. So even though it's not higher than that younger group, it's 5 times higher than it would typically be from previous studies. And although the 65 and over group is higher than usual, it's only twice as high. So it hasn't had the same impact on the older cohorts as it has the younger ones. Here's some other characteristics. Again, this is very similar to the previous data. Single people, much higher rates of depression than married and other marital statuses. Lower education, high school or less, 28% with moderate to severe depressive symptoms versus 21% if you have a post-secondary certificate or degree, including university and so on. And then the lower income groups, again, so if you're making less than $20,000 for your total household income, more than a third of you are expressing moderate to severe depressive symptoms, and another third mild depressive symptoms. So I want to look at what the distribution of these depressive symptoms were across Canada in terms of regions. And we're actually finding that in BC and Ontario, they're actually the most likely to show this moderate to severe depressive symptoms. In British Columbia, 1 in 4 residents are showing symptoms, and even more in Ontario at 27%. Now, if you go to all the other way to the East Coast, Quebec and Maritime residents, they're actually the least likely to show depressive symptoms. So you see that final category, that last column there, no or low depressive symptoms. Again, this was on a 0 to 24 point scale. So the 0 to 4 range, 3/5 of both Maritimers and Quebec residents are on that no to low depressive symptom category. And you can see overall that in Canada, it's about 47% that are showing some form of depression, either mild or moderate to severe. And this was also brought up in the regression analysis, but you can see that those who have lost their job and pay permanently, it's really affecting them the most in terms of their mental health. 78% of Canadians who have lost their job and pay permanently since the beginning of the crisis are showing signs of at least mild to all the way to moderate and severe depression. If you look down here in terms of those individuals who report that the crisis has had no impact on their job, it's only 41% that show signs of depression. So it's a much higher gap there. And again, in previous studies, signs of depression would be about 22% amongst the population, Canadian population. So we did a couple crosstabs here just to look at depression and how it relates to other social and voluntary behaviors. So one thing we were interested in was, in the last week, have you volunteered for a charity? And you'll see that those with any signs of depression, either mild or moderate, 7% reported that they had volunteered for a charity in the past week, compared to only 4% of those who weren't showing any signs of depression or very low signs of depression. And while that gap might not seem that large, it is significant. If you look at the chi-square here, it's significant at a p-level of 0.08. We also looked at, would you be willing to volunteer your time in a senior's residence be it a senior healthcare facility, CHSLD, where there are some reported cases of COVID-19. And we see even a larger effect here. Those who are willing, about 1 in 4 in general, 26% with mild depressive symptoms and 23% with moderate to severe depressive symptoms were actually willing to volunteer at a senior's home with the reported cases of COVID-19, compared to only 19% of those who have no or low depressive symptoms. And that was even more significant at p-level of 0.02. Also, another thing we've been measuring in our weekly surveys of the Social Impacts Network is Canadians' readiness to re-engage in public life, is what we're calling it. And it's based on a number of measures like dining in restaurants. How comfortable would you be once the measures, the social distancing measures are lifted by government? How comfortable would you be in dining in restaurants, going back to your workplace, shopping at the mall, at farmers markets, using public transit, traveling to the US or flying on an airplane and so on, attending large sporting events? And you can see in general, if you have no or low depressive symptoms, you're much more likely to re-engage on a lot of these measures. So almost half of you are willing to dine in a restaurant if you have low depression or no depression. Almost 4 out of 5 individuals are willing to go back to their workplace or office, compared to only 68% if you have mild depression and only 54% if you have moderate to severe depression. So down the line here, you see there's quite a big gap in terms of those who have depression and those who don't, and their readiness to re-engage in public life. Now, I've highlighted some of the things here that the items that there weren't very large gaps. So if you look at using public transit, there's only about a 4-point gap between those who have moderate to severe depression and those who have no or low depressive symptoms. So there wasn't that much of a difference. Same with attending large concerts or sporting events or festivals, 22% moderate to severe depressive symptoms versus 23% for no or low depressive symptoms. So in this case, I find that even though there's no difference, I find that to be interesting. And same with traveling to the US and flying on an airplane, there weren't very large gaps in that regard. And this, we've already kind of touched on this, but this was just a replication of the regression analysis on a national level. And as you see, fear of contracting the virus is a big predictor of your mental health in terms of it. If you have fear, you're going to have increased mental health, depressive symptoms, lost job and pay. And even in the national study, we found the lost sum of your pay or income from work was also significant. And that's after controlling for those sociodemographic measures. And that's all I have for you for today.
Thanks so much, Dr. Schmitz and Dr. Hawley. We'll now be turning the presentation over to Jack Jedwab, with whom none of these conferences and most of this data might not be available. So I'll pass it to you, Jack. Jack is the chair of the Canadian Social Impacts Network.
So, thanks, Jen, and let me just set this up. Got it. Yeah. So thanks, everyone. I'm going to also present some data from the work we've been commissioning with Léger Marketing. This was done on the 15th to 17th of May. That is the survey, both in Canada and the US. And what distinguishes it from the previous presentation is that the sample being looked at is the group that has said they've been diagnosed with depression. So we're not looking at the general population in terms of mild or severe symptoms potentially that are associated with depression, but rather a body of people in the national survey that have indicated they've been diagnosed with that condition. And just to be clear, the sample is not looking at people who say they are currently diagnosed with depression, but rather people who have been, may be currently and or have been diagnosed with depression, and what their feelings are in the wake of the COVID-19 outbreak. So this is just the methodology. As I said, May 15th to 17th, 1,512 Canadians and 1,005 Americans. It's again a non-probability sample, so no margin of error can be assigned to it. but it provides, I think, an important snapshot and some interesting insights that will permit us, along with what we've seen previously and what we're going to hear in the next session, to identify the research questions that are important for us to best determine the types of policies and programs that we can build on from what currently exists, and or develop things that are new to dealing with the evolving situation. These are just what I would say are the demographics associated with those people who have indicated in Canada, United States, they have been diagnosed with depression. In Canada, 14% of the sample reported such a diagnosis. You can see that it's 19% in the cohort that is 18 to 24, slightly higher for females and males at 16%. United States, somewhat higher, 20% overall say that they've been diagnosed with depression, at least in that sample. Again, higher for females than for males, in fact, considerably higher for females than for males. And as you can see, also amongst the younger cohort, we're seeing that it is a 23% thereabouts in the 18 to 29 group. Next, we can see for the regional variation with respect to the percentage in Quebec. It's actually lowest in Quebec, somewhat consistent with some of what Paul was presenting before, although it's considerably lower in Quebec in terms of those diagnosed with depression across the country. Again, it's a snapshot in time. There is data available, I suspect, although there's confidentiality issues associated with sharing of such data, I would presume, in terms of the variation. But at this particular juncture, Quebec is showing a lot lower percentage of people indicating in the survey that they've been diagnosed with depression. In the US, the percentages are fairly consistent across the 4 regions, Northeast, Midwest, South, and West, all around that 20% mark, which is associated with the national average there. So really, Quebec is a bit of an outlier with respect to those indicating in the survey they've been diagnosed with depression. On the basis of income, those indicating they've been diagnosed with depression, it's most prevalent for persons with lower income, reporting lower income. That's the case both in Canada and the United States. On the other end of the spectrum, the higher income earners are reporting far less, to a far lesser degree, that they've been diagnosed with depression. So that just sets the sort of demographic characteristics, at least as regards the people who are reporting that they've been diagnosed as such in these particular national surveys in the 2 countries. Now to go quickly to the possible effects on those people who've indicated they've been diagnosed as such, relative to some of the social dimensions and some of the economic dimensions of the survey inquiry. So what you can see here, if you go to the top row on the table that refers to the issues in the United States, you can see that those people who say yes, they have been diagnosed with depression, some 35% are very afraid of contracting the contagion, COVID-19, versus about 24.8 or 25% of those who have not been diagnosed as such who are very afraid. On the Canadian on the table referring to Canada, very similar in terms of the gap, about 10 points between those persons who are saying that they have been diagnosed with depression and who are indicating they are very afraid of contracting COVID-19 versus the ones who have not been diagnosed with depression, where 15% are fearful of contracting COVID-19. So clearly, as some of the other presentations have indicated, there is a relationship, at least at that higher end, between fear of contracting contagion amongst those people who have been diagnosed with depression. Next, in Canada, United States, people who reported being diagnosed with depression were far more likely to report bad mental health since the beginning of the crisis. Now, we all have to be careful because the way in which the questions are structured is sort of trying to tap into the extent to which you're feeling worse or better or so forth, and laying out the options as such. But we need to sort of be mindful of sort of the sample that we're working with here. But this probably is the most important element that I found in the mining or analysis of the data, around those individuals who are diagnosed with depression. Because in effect, what they're saying, if you look at the table and you look at the for the row indicating bad and very bad, or those two rows, and look at the numbers in red, you can see that you accumulate that, and you've got about 38% of people in Canada who are reporting having been diagnosed with depression, saying that since the beginning of the crisis, they rate their mental health as bad or very bad. That in comparison with those people who have not been diagnosed as such, where 11% are reporting that since the crisis, their mental health self-evaluation is bad or very bad. That's a substantial difference and a very high number, or rather percentage relative to the overall survey. In the United States, similarly, those people diagnosed with depression, you can see the numbers in red, the bad and very bad combined, about 30% total versus about 7.7% for those people who have not been diagnosed with depression, who are saying that their mental health is either bad or very bad. So that's a key issue that we need to further investigate, which can be done obviously with some clinical trials for people who have been diagnosed and currently diagnosed with depression, to get into what the potential impact is of the worsening or perceived worsening and severely of the condition of those individuals who have been diagnosed as such. One last thing, and just is the data on stress when leaving the house. So you can see this is the question we've asked. These are the broad results, the overall results rather, on that question. You can see that stress, the question being when you leave your house and you're out in the public, to what extent do you find that stressful? Some 64% of American respondents say it's stressful, with 22% saying it's very stressful, compared to Canada, where it's less stressful at 51% reporting overall that it's stressful going out to public, with 9% saying it's very stressful. So a big difference, at least in terms of the extent to which people going out of their homes in the public during this pandemic find it very stressful. Now let's look, however, at, in this case, across the age spectrum, where I've broken this down, what the responses are for people who have been diagnosed with depression or not. And the people who have been diagnosed with depression, you can see across Canada, across the age cohorts, are reporting quite substantial gaps, especially the upper age cohort, in the extent to which they feel stressed going out in public. That is to say, those people diagnosed with depression relative to those people who have not. The gaps are ranging from 10 points to as much as over 20 points when we get to those upper age cohorts. Similarly, in the United States, we also are seeing some gaps, although exceptionally in the 18 to 29 category, that requires some further investigation, I presume, but we're not seeing the same pattern we've seen in the other age cohorts with respect to the gap between those diagnosed with depression and not, as regards the extent to which it's stressful to go out in public. So in closing, where do we go from here? Well, we'll get some answers from the next panel, but as regards research questions that need to be asked on the basis of what you've seen in the last 3 presentations, or 2 plus my own, I'd invite all of you to as much as you can, share your thoughts, comments, and observations with us, so that as we develop a plan going forward, and we're going to be in this for a while in terms of seeing how everything that's occurred up to this point unpacks or unwinds going forward, what type of questions we should be asking, and if we're not asking the right questions, what do you suggest we need to do going forward? We're very open to that, because we'll all need to work together and bring to bear our knowledge from the diverse areas that we have expertise in, to determine what types of questions need to be asked, and then what types of policies and programs we need to develop going forward. Thank you very much. Merci beaucoup. Désolé, j'ai pas parlé en français et on n'a pas beaucoup de temps, le temps presse. Toutes les présentations vont être disponibles sur notre site web dans les 2 langues officielles dès la semaine prochaine. Et si vous désirez poser vos questions ou présenter vos commentaires en anglais et en français, soyez libre de le faire et on va répondre dans la langue auquel vous posez vos questions. Merci beaucoup et à bientôt. Thank you.
Thanks so much for that, Jack. You'll be happy to know that there have been a lot of questions being posted in the Q&A. We only have approximately 10 minutes to answer those in this panel. But what I'll try and do is pose 1 to 2 questions to each of the panelists separately. And if there's not time to answer everything, audience members can be assured that we'll get back to them in writing or via another method afterwards. So to begin with, Julie, et tu peux répondre en français, s'il vous plaît. How can people without access to technology have their voices heard in Statistics Canada data? So that's one question for you. How can everybody access the surveys if they don't have internet or other technology? And a second question for you, Julie, is how is Statistics Canada taking into account gender diversity and measuring groups other than the standard 2 binary ones, female and male?
Yeah, thank you for the question. So the first question about people not accessing survey, in general, when we do survey Statistics Canada, depending on the topic and depending on also the area, we sometimes do in-person, which we often do in health, in-person interview. We sometimes do telephone interview, and we sometimes do on the web. Most of the time nowadays, people receive a letter saying you've been selected to be in survey X or Y. Here's a link where you can go and answer. If you prefer us to wait, to talk over the phone, wait, we're gonna phone you around that date. So often we let the respondent decide. In that case, because we wanted to get results so fast, because it was a matter of having a pulse of what was going on, but a very timely matter, we used the technique that we call the web panel, which means we took one of our survey that was already on the field, the labor force survey, and we contact only the respondents that were already opting for the internet as being their favorite way of being in contact with us. But it was just for a matter of speed, because as you might like figure out, sending letter out, getting people address from a registry, sending letter out, giving them 2 weeks to decide if they go on the web or over the phone, phoning them 3 times until you get access. Like it's a typical 4 to 6 weeks to contact a respondent. So in that area of crisis, we use a web panel. Web panel, we already had it in mind. It has been designed like 1 year ago, and we had it in mind as a way to respond to emerging crisis. So usually we give more people a chance to answer the survey. And the second question was about gender. So Statistics Canada, over not this year, but a 2 former year, worked a lot with multiple federal and provincial government and different advocacy groups on defining a way to ask the gender question, or to change the way we ask for sex, or have a minimal set of questions that will bring us to having the category that we should have instead of only having male and female. So a standard has been developed. It's become the standard that will be used when you fill questionnaire for the federal government, be it unemployment questionnaire, you ask for a health card. So it's becoming the norm. That's how the question will be asked in the census. But as of now, it hasn't been integrated in all our survey tools. And don't forget that even when it's integrated, that doesn't mean we'll be able to report on the result, because we follow really strict confidentiality rule. As an example, the web panel is constituted of 4,200 respondents. It's not likely that we will be able to use gender as a qualifier, just because of the number of respondents. But when possible, as an example, in the census or in administrative data, yes, we're moving toward always reporting gender.
Merci beaucoup, Julie. Moving on to Dr. Schmitz and Dr. Hawley. I have quite a few questions here, so I'll pose a couple of them and you can pick which ones each person gets. There were questions about how seniors in care homes or long-term care homes are doing with their mental health versus seniors at home. We've also received a question asking if there's previous studies that compared how people's mental health was in maybe more localized crises like fire, earthquake, floods, violence, or war compared to what's happening in COVID. And I'll leave you with those two to begin with. So Dr. Schmitz or Dr. Hawley, did you, either one of you want to reply to one of those two questions?
Yes, thank you very much. I can start with the last one. So what we see from other crises, there is a peak in depressive symptoms and in mental health problems. And so we have to be very careful here at this point. So we see a high level of depressive symptoms, but probably not everybody needs treatment right away. So it might not be the best strategy to say everybody needs psychotherapy or antidepressant medication. So we see this peak, but it might go down for a lot of people if things go back to normal. So what we really have to do is, at least from a research perspective, to monitor over time, to see what happens over time. And it becomes really dangerous and difficult if depressive symptoms and stress gets chronic. So this might have a big effect on physical and mental health. And that's what we've seen from other studies during 9/11 or a lot of other natural disasters. So there's always a peak, and it's a human reaction to a different condition, to stress. But if people can adapt to it, usually it works out good. But for some people, it means there is a level of chronic stress and chronic depression, which we have to monitor very closely. So this would be important to do this here over time, to follow people over time and see what's happening.
Thank you for that.
I know, sir, there are a couple other questions, but if you wanted to.
You can do those as well if you'd like to, Paul. I wanted to save the questions about how immigrant families are doing for you and Jack specifically, because I know you have a lot of expertise in that area, and also conclusions about provincial disparities in mental health. So if those were the Q's and A's you saw, or any other ones, feel free to go ahead. Yeah,
certainly. I saw the question about newcomers and immigrants, and that's obviously it's an area that we're very interested in. And the reason I didn't report specific results on it, because we just in this particular week we didn't have a sufficient sample size really to break it down by newcomer status or established immigrants. However, I can say that if you look at just immigrants and Canadian-born population, there is a slight increase in depressive symptoms amongst immigrants in general. I mean, we're talking about like a 3-point gap only. From that survey week in particular, we only had 56 newcomers that responded to the survey. I can say that amongst those, it was much higher in terms of depressive symptoms, like staggeringly higher. However, I don't really want to report the numbers because of the small sample sizes. And with regard to the provincial disparities, there was a question about Alberta. They weren't actually higher on the moderate to severe depression, but in the mild depression, they did have higher rates. I think about a third of Albertans, as I recall, had some form of mild depression, which was about 10 points higher than the rest of Canada.
Thanks, Paul. Did you or Jack want to comment on how seniors in care homes are doing as compared to seniors in their homes, or if there's any data on that topic? Or Jack, did you want to add anything else to the questions that we've already posed in this discussion session?
Well, I think I'll add to what Paul said with respect to newcomers, and intersecting with newcomers, obviously, are issues about the collection of race-based or visible minority data, as opposed to the question about seniors and senior and care facilities. There's much more data that needs to be collected about the issue of senior and care facilities. We're actually working to see about collecting data in that regard with some potential partners, and anyone who's interested in working with us on that is more than welcome to do so. But clearly that's going to be an issue we need to look at urgently, and yet we'll need to look at it over a proper time span with the right data in hand to do so in a specialized way, including looking at issues around frontline workers, which would also be another critical area to look at in terms of, as well of how that intersects with issues around depression and anxiety and so forth. I did want to speak to the issue quickly of immigrants and newcomers and various categories of immigrants, including refugees. Paul did mention that sample sizes, regrettably, were very limited in terms of what we've been able to secure by way of resources from stakeholders to do the research in that area. But it's a vital area. And I was very glad to hear Anna Romano speaking earlier about the collection of race-based data by the Public Health Agency of Canada. There's been a lot of talk about that, both with other researchers, with policymakers, in some of the media. I've been, as have others, quite vocal in public space, in media, in saying that it's absolutely critical to collect that data. And from what we've been able to collect thus far, again, with the modest resources we've been able to secure, we've noticed on questions of employment and income, where there are high rates of vulnerability, there's a clear relationship with some of the depressive symptoms and some of the potential for the so if you like, the relationship between those who are suffering from those symptoms in the general population and the diagnosis of depression. And there's an important distinction that needs to be drawn there, and something we need to think about. But it's the sectors of society that are most vulnerable that are really susceptible, as we've seen, to falling into those situations more readily. So I guess I would say, without providing any data conclusions, that we absolutely, c'est impératif de faire tout notre possible pour persuader et convaincre nos décideurs de collecter les données sur les minorités visibles et, de plus que possible, permettre aux chercheurs d'avoir un accès assez facile à ces genres de données. Je n'enlève pas Statistique Canada, je suis un très grand fan de Statistique Canada. Ils sont fantastiques. J'ai beaucoup d'expérience avec notre agence, très fier des personnes qui travaillent pour Statistique Canada et les personnes comme Jen Kadatz qui ont déjà travaillé pour Statistique Canada. On sait que, malgré le travail fantastique, il y a des limites à ce que StatScan peut faire dans le temps réel. Et on est dans une situation où il faut être extrêmement rapide en termes de collecte des données afin d'identifier des problèmes qu'on confronte actuellement et là, dégager les conclusions. Alors, je le répète, I'm repeating for the severalth time, I'm inventing that word, for the, this multiple time, it's absolutely critical for our decision makers to invest in the collection of data on the basis of visible minorities as regards some of the issues that we're dealing with in real time, right? As opposed to wherever this is occurring, to the extent there is some pushback on this, that people feel it's one size fits all. We're all Canadians. The contagion is affecting all of us. It doesn't select amongst us. That's true, but it does affect some of us disproportionately who are vulnerable. And every body of data we presented so far has demonstrated that.
Oh, thank you, Jack. I was hoping to have time to pose to each panelist the question, wouldn't it be great if, where you fill in the ending to that yourself. I did not have time, although I think Jack just gave us his. Perhaps everyone in the panel could do that in the Q&A section or the chat section of this board, and so can our audience members, and then we will know what each of you wants most following this presentation. Thank you, and I will now pass the mic back to Tasha again.
Thank you so much, Jennifer. Thank you to the whole panel, Jennifer Kadatz, Julie Bernier, Norbert Schmitz, Paul Hawley, and of course, Jack Jedwab. And I think, Jack, you made the point so well, summing up pretty much the whole conversation at the end, which is without data, you don't know. And there are definitely groups that need to have more assistance than others because there's a disproportionate effect. Les impacts de COVID-19 ne sont pas égaux parmi la population et les impacts sur la santé mentale, certainement pas non plus. Alors, il faut avoir ces informations. Alors, merci à tous les panélistes et les informations fort intéressantes et les grandes différences qu'on voit déjà qui sont importantes pour ceux qui font les décisions en gouvernement et comment aider ces gens-là. So we'll go now to our panel number 2. And for this, I am very pleased to introduce our chair, Hubert Lucier. Hubert Lucier est maintenant retraité, mais il était anciennement le sous-ministre adjoint pour Patrimoine canadien. Patrimoine Canada, pardon. Il a été en tant que fonctionnaire fédéral, il a passé la plus grande partie de sa carrière à ce ministère. Et en tant que sous-ministre, il a fait progresser les dossiers des programmes, des politiques et les lois concernant la diversité, la langue et les questions et participation des citoyens. Alors, Hubert, the floor is yours.
Merci, Tasha. So we've heard convincingly that there is a link between the mental health of people and this COVID situation. Et la session que j'ai le plaisir de présider va explorer certaines des réponses qu'on peut apporter à cet enjeu. So we have a formidable set of experts who are quite competent in dealing with this issue. We have three panelists. I will briefly introduce them right now and say a few words in addition when they start speaking. Donc, pour vous les présenter, Mary Bartram, elle est directrice de la Mental Health Commission of Canada pour le dossier COVID-19. She will be followed by Dr. Keith Dobson. He is Professor of Clinical Psychology at the University of Calgary. And finally, we'll have Deborah Giddis, the President and CEO at the Center for Addiction and Mental Health Foundation, CAMH. Donc, le docteur Mary Bartram, qui va commencer par nous faire sa présentation. Je l'ai présentée comme directrice, donc Mental Health Commission of Canada. She has had a long experience working in the public service, first of all, and with federal and territorial governments, also with Indigenous organizations and NGO. She is the former director of the Mental Health Strategy for Canada, and she also holds a PhD in public policy at Carleton University. She gives courses at Carleton in public policy administration. Dr. Bartram, I'll leave the mic to you now.
Thank you very much. Merci beaucoup. I'm just sharing my screen here. And okay, thank you very much. Merci tout le monde. I'm going to talk a little bit about some of the work of the Mental Health Commission of Canada. As you can imagine, with the onset of the pandemic, the importance of considering policy issues was very much front of mind for my colleagues at the Mental Health Commission of Canada, and we've been able to launch a small policy research initiative over the past weeks, and I'm very pleased today to be able to share some of the initial thinking and findings coming out of that initiative. So from the outset, before some of the data that the other panelists today have shared was available, we put our minds to what could we conceptualize as potential impacts based on our theoretical knowledge and conceptual thinking about the relationship between mental health, substance use, and various risk factors. And so this was sort of our initial framing, taking a kind of basic population mental health model, what would we need to prepare for to the extent that we could anticipate a surge in demand and harms, moving up the population triangle, and also anticipating a potential interruptions in the supply of services and the capacity of the service providing workforce, either as a result of illness, redeployments, and of course the shift to online services and the challenges with providing face-to-face services. At the same time, the importance of, while anticipating those effects, also continuing to anticipate resiliency at all levels. And one of the things I can just flag in here is the importance from a primary prevention perspective of social connection, which General Dallaire spoke to very powerfully at the beginning of this conference. So our next step was to undertake a preliminary policy scan. So this work was completed basically in the first 2 weeks of April, at a time when the infection rates were increasing at a far more alarming rate than they were now, when we were kind of steeply climbing towards the peak here in Canada, and also bearing witness to the peak of the pandemic outbreaks in many countries around the world. So our aim was to identify policy considerations and emerging issues amidst that first wave of COVID-19, with a focus on unmet and anticipated needs of vulnerable populations, healthcare providers, and the mental health system. And we did this sort of through a multi-pronged approach, a rapid review of academic literature. So there it was primarily focused on literature from other epidemics and disasters, although there's been some, even by then, academic literature emerging from China. Analysis of media reports. We did an international scan that included key informant interviews with people in many different countries around the world, as well as with key stakeholders to gather perspectives and experiences here in Canada. So I'm just going to talk briefly through some of the key findings. So the first one was that there's been a tremendous response to the mental health impacts of the pandemic, but that this is leaving some behind. And what struck me very powerfully in doing some of those key informant interviews with people in other countries was how similar both the mental health impacts at that time and the responses from a policy perspective were. So it didn't matter where I was talking to someone, people were all more or less saying the same things. First, that there'd been this tremendous rapid response mounted to meet the needs of the general population, and that included a big push around dissemination of wellness information out to the general population around how to take care and protect one's mental health during a time of tremendous stress and anxiety, coupled with that quick pivot to virtual services and supports that was really targeted to getting counseling and therapy supports to the population as more of that sort of secondary prevention level. But these responses, people were flagging concerns even in the middle of in the middle of April, that have continued to be amplified since then around how those responses were leaving key vulnerable populations behind. So that would include people with more serious and complex mental health and substance use issues, but also, as was just discussed, people from racialized communities, newcomers, you know, even to some extent youth, as we saw the heightened or the disparities in terms of how these mental health impacts are being felt across the lifespan, and so forth. So a second key finding was that COVID presents an opportunity to both prepare and transform the system. So in part because we know from, if the pattern holds, we don't know yet, that other disasters and epidemics, there's been sort of this lag in mental health impacts. So we can anticipate that we haven't quite gotten to the height of what those impacts might be. But also that as we kind of have flattened the curve to different extents across the country, that there's a window of opportunity to ramp up planning now. So I think Bonnie Henry talked about this in terms of the opportunity to regroup. And you can see this reflected in the quote from this key informant in Canada, that there's an opportunity to engage in meaningful conversations with service users, providers, and mental health services to create a post-pandemic system that incorporates innovations in virtual care while not leaving behind the transformations that were underway prior. A third key finding was around the critical importance of focused attention, not just on health care providers and their mental health needs and the impacts on them, but also on the mental health provider workforce. So the mental health and health workforce is the backbone of the health and mental health systems. That's been true that's always been true, but now is a time to really pick up an important piece of work around identifying the needs and the capacity of those workforces to really meet anticipated increase in demand that we can predict based even from the data that was shared this morning. So the one other thing I just stress from here is the importance that we do this work, not just in the public part of the mental health and substance use systems, but also the private part. So with our history of gaps and inequities in funding for both the mental health and substance use sector over decades, we've developed a strong role in the private sector in things like EAPs, access to psychological services through employment-based benefits, and private addictions treatment. And if we don't include those systems as part of our planning and response, we'll really be missing the boat. And you can see this quote from a key informant in Europe talking about how all of this going on in the context of an epidemic, that something like PPE has been such a priority that it's really swamped the possibility for prioritizing the mental health workforce. So another key finding, echoing something I was talking about a little bit earlier, that mental health impacts can be expected to be delayed, complex, and long-term. That, you know, again, that we have this window of opportunity, but echoing some of the other speakers, this caution against a one-size-fits-all approach. So just even geographically, what people are experiencing in different regions of the country is quite distinct. It's fascinating how with the highest impact in Quebec, we're seeing such a difference in the rates of depressive symptoms and people reporting having been diagnosed with depression. So that's quite an interesting research puzzle. But also, you know, within urban areas, outside of urban areas, some of the disparities that have been mentioned in terms of how this is impacting different groups who are experiencing racism or are racialized. By age, as I mentioned before, and also the disproportionate impacts on frontline and essential workers. So the last key finding is around the importance of fostering resiliency. So as I mentioned when I was describing that population mental health model, the importance of balancing the raising awareness about increased prevalence of mental health problems and illnesses or symptoms thereof, balancing that against the risk of pathologizing normal emotional responses to what is undoubtedly an unprecedented and highly stressful situation, and supporting people around the meaning making and post-traumatic growth and resilience that's necessary to buffer people's psychological health. So again, picking up on what General Dallaire was talking about this morning, you know, encouraging people to find ways to make meaning, to contribute, and so forth. So next steps over the coming months, the Mental Health Commission will be working in collaboration with key partners to address, to provide additional policy advice in response to COVID-19. And we do have a lot of resources already that are available through the hub that's listed here. So thank you very much.
Thank you very much, Dr. Bertram, and thank you. It's reassuring to know that the Commission is there to provide an answer and some advice to the different decision makers that will need to deal with this issue. I shall remind, je veux rappeler à tous les participants que s'ils veulent poser des questions, il faut utiliser la fonction Q&A. So please use the Q&A function on your computer to ask questions rather than the chat one. It's preferable because there will be a question and answer session at the end of the three speakers' presentation. So the next speaker is Professor Keith Dobson, University of Calgary. I'll say a few other words. He's been an expert whose research has focused on the cognitive models and the mechanisms of depression and the treatment of depression. He has a considerable set of publications. It's mind-boggling, 270 published articles and 15 books he contributed to. He's been the principal investigator for the Opening Minds program of the Mental Health Commission of Canada. Il a aussi il a occupé plusieurs fonctions en tant que président ou directeur de différentes associations. He was president of the Canadian Psychological Association. He's a past president of both the Academy of Cognitive Therapy and of the International Association for Cognitive Psychotherapy. And he is the current president of the Canadian Association of Cognitive Behavioral Therapies. Monsieur Professeur Dobson, je vous passe la parole. Professor Dobson, the mic is yours.
Yeah. So I don't know if people can hear me or not, but thank you very much for that introduction, and thank you to the Social Impacts Network for the opportunity to speak today. What I'm going to do is focus, not surprisingly, on risk factors related to mental illness and some of the interventions that I think the evidence tells us are things that we should be considering. Just going to share my slides. Whoops. Jump back to the beginning. And that should be full screen now. Can somebody confirm that?
Yes, you are on screen.
Very good. Okay, very good. So what I'm going to do in my presentation is talk about mental health, of course, during the pandemic, and some of the risk factors that we know are evidence-based associated with mental illness, and some of the potentially effective responses. What I'm going to do is be talking about literature from the past. And again, there's no reason at this point in time to believe that the risk factors or the treatments that we have for general mental health problems should not also apply in this era, although that's going to be an empirical question. And again, we've already been hearing from presenters about the importance of ongoing data collection and information gathering, which I know is going on at the clinical level as well as the epidemiological level. One of the things that we know in the psychology of anxiety and stress is that there are three primary factors associated with increased risk for stress. And these are unpredictability. So when risk factors or stressors are unpredictable, or we don't know the nature of the stressor. When they're uncontrollable, so we don't know how to effectively respond to the stressor, even if we know what it is, and if the stressor has high personal importance. And in the context of COVID-19, you could argue we have the perfect trifecta of risk factors because especially in the early days, we didn't know much about the disease, and we certainly are still learning a lot more. Our controllability is limited. There are only certain things that we know that we can do based on public health advice. And so there's lots of uncontrollability and lots of concern because of that. And of course, the risks are high. So in that context, it's not surprising that this would be a highly stressful condition. Not surprising also that we would find rates of anxiety going up, especially in the early days. There was good evidence in the very first month or so that rates of anxiety and stress had gone up dramatically. And it was predicted, and as we've just heard in some of the previous presentations, it was predicted that rates of depression would go up once we got fully into the pandemic. And we're obviously seeing that kind of an effect now. We actually had predictions early on, again, that rates of substance use, domestic violence would also increase. And again, unfortunately, we're seeing those kinds of risks as well. It can be anticipated that as this pandemic continues, that rates of anger and anger-related issues will also tend to go up. And again, from a psychological perspective, anxiety tends to be a future-oriented emotion. So we look forward and we worry about the future. Depression and anger tend to be more past-oriented emotions. We get depressed about things that have happened or things that are happening, and we get angry about things, again, in the past, injustices that we believe that we've observed. So we could anticipate, again, that rates of depression and anxiety probably will continue to increase, and that anger will also increase over time. When we look at risk factors generally for mental illness, again, most contemporary models try to take a biopsychosocial framework. So they look at these three broad classes of risk factors and try to identify those that fit for a particular condition. And of course, for any given disorder, the specific risk factors will vary somewhat. What I've done in the 3 slides I have next is take from the literature those 3 risk factors or classes of risk factors that tend to pop up reliably, and I've highlighted those that I think are particularly relevant in the context of the COVID-19 pandemic. So these are biological risk factors. They include things like genetic risk, family transmission, brain or neural structures, neurotransmission processes. And the 3 that I think are particularly relevant here now are sleep dysregulation, which we hear is a common symptom associated with COVID-19, general system arousal, autonomic nervous system arousal, so stress and anxiety as responses, and gender. Gender, unfortunately, has been an ongoing factor associated with mental health risks, and we just heard data earlier today even that this continues to be true in this context. Psychological risks are endemic, I think, within the context of a situation like COVID-19. So our beliefs or assumptions about the world and the way it should operate are being challenged currently. We know that people are engaging in biases in the way that they're collecting information and paying attention to information. The selective attention, for example, in media reports and overemphasis on negative predictions is certainly part of the biases that we're seeing. We're seeing general pessimism. This is being tempered, of course, by people that are talking about optimism and resilience, like we just heard. But again, there's a general tendency. Blaming, again, negative explanatory styles for problems, making negative attributions, ruminating, a lot of worry, rumination, avoidance. We hear, again, people engaging in a variety of strategies to isolate or to do things that are not that productive. So these are all being played out in different populations in different parts of the Canadian population. We also know about social risks. So parental psychopathology and parenting style are especially risks for childhood psychopathology or mental health problems. We've heard again of some reports of parenting styles that are causing increased stress for children. So this is probably true here. Adverse childhood experiences, child abuse and neglect are general risk factors, attachment issues, but in particular, negative life events, so unemployment, which has been a real concern, of course, in Canadian society, loss, either real loss in the sense that people have lost their lives or the threat of loss of lives. For some people, again, has been a significant negative life event. Relationship issues we've heard about again. Social support, especially with physical distancing, of course, has been diminished. And then lots of people engaging in reassurance seeking and trying to get support from others. I won't talk about stress generation. That's a bit more complex construct, which probably doesn't apply in the context of an actual risk like COVID-19. But the bottom line is that there are lots of evidence-based risk factors which we know are associated with mental illness in general, and many of these are highlighted during the context of a pandemic like the COVID-19 situation. We also know that there are some evidence-based protective factors. So, building on Mary's presentation that you just talked about, building resilience. We know that people that have a strong temperament or ability to withstand stress in general tend to do better. People that engage in regular physical activity and try to maintain regular sleep. People that have more positive or approach coping strategies, so they try to solve problems rather than avoid or minimize them. People with better social skills and personal competence, and people with strong relationships and connection. These are all protective factors that have been shown in general for mental health. So these are all critical factors. The truth is, of course, that the risk factors I talked about, and we've heard about this through several presentations, are not equally distributed across society. We know that there are particular groups who are vulnerable. including immigrant and refugee groups, people with a history of mental illness, people with existing physical illness, youth, we've heard, again, are particularly susceptible to some of these stressors. So again, even though we know a bit about the general risk factors, they need to be considered in the context of each particular individual. So when we look at the impact of these factors, we need to both look at them from a systemic or epidemiological or social level, of course, but at a clinical level, we need to investigate and assess people at a one-by-one level and figure out which factors are most important for them so that we can target treatments directly to that individual if possible. So these are some of the general conclusions about risk that they present across a wide range of different kinds of conditions, and that probably one model is not going to fit everybody, and that we need to do individualized assessments to figure out what treatments might help individuals. Some general comments about treatments that work, and then I'll offer a few ideas in the context again of COVID-19. First, there is no single treatment that's going to work for everyone. There's no one evidence-based treatment for any given mental disorder. Again, practitioners and research suggest that there are sometimes better treatments, but again, people need to find the one that works for them. Most validated treatments for most treatment conditions have about equal outcomes. So if one treatment doesn't work, it's a good idea to look at other options and try those. Combining treatments may be indicated, but typically for those people that don't respond to lower levels of care. In fact, in mental health generally, we're now often moving to a stepped care model with individual treatments offered early and then combinations only for people that need ongoing care or who don't respond to monotherapies, single therapies. Validated treatment should always be the first course of options. So again, there are many unproven treatments or recommended ideas out there for COVID-19. My bias is always go to the evidence, find out what actually the data says, and go to those treatments first. Earlier treatment in mental health is almost always associated with better outcome. So the earlier somebody recognizes they're struggling, they should start to monitor themselves and look to get some kind of assistance. Focusing on the current problem is important, of course, but also is preventing relapse. Again, a lot of mental disorders, as we heard earlier, tend to be chronic. So the earlier that somebody can get assistance, the better. And again, don't just focus on the current issue, but monitor functioning over time. Risk assessment may need to be done. There are reports that increased rates of self-harm and self-injury are going up. So again, this needs to be an ongoing assessment. And one of my recommendations is to look at the United Kingdom. There's an agency there called the National Institute for Clinical Excellence. This website gives very good evidence-based guidelines for the assessment and treatment of a wide range of mental disorders, in fact, all health conditions. Health Canada, of course, also provides a similar kind of information. So what can we do? Turning to the positive aspects of this as quickly as possible. I think we need increased surveillance and assessment without a doubt. And we've already heard recommendations that we need population health data, looking at disadvantaged people in particular in their response to COVID-19. At the individual level, we also need ongoing personal assessment to help people know what their current functioning is. One of the tools that I recommend was developed by the Mental Health Commission of Canada and has been validated, and this is the Mental Health Continuum model. It's a very simple framework. It puts everybody on this continuum, says that we're functioning, it uses a color coding system of healthy, reacting, injured, and ill. But again, it gives you signs and symptoms that you can look at that can help you to assess where you are on this spectrum, and if your functioning is changing in particular, because that's a key issue. We also need people to ask their friends and family. If you're in doubt about how you're functioning, or if you think that you're changing and you're not functioning well, ask, reach out, and if necessary, get help from your family physician, or if you have access to an EAP service, you can certainly do that as well. We also know that there are a number of good evidence-based strategies that are generally being encouraged to adopt. And again, many of these are not new, so I'll just go through them very quickly. But just to reinforce them, we should try to maintain our routines as much as possible. So we should have a regular sleep-wake cycle. We should try to maintain our eating at regular times. If we work, we should try to keep our work within a constrained period of time so that we can protect our time for ourselves and our families as well. We should exercise. Population health recommendations are 3 times a week. More is better often, but again, each person needs to figure out what's appropriate for themselves. Get outside. It's now summer, early summer in Canada. So again, if you can, get outside as much as possible. Enjoy the sunshine and take your mind off of issues inside the house. Watch your self-talk. Again, we notice again that worry and rumination are key risk factors for lots of mental health conditions. So if you find yourself engaging in those activities, there are strategies that you can adopt, and again, I won't go into them now, but there are many of them. One of the specific recommendations, though, is to turn down the media noise. So again, if you find yourself spending a lot of time watching the news cycle, try to avoid that if you can, or reduce it. Schedule activities. Again, we recommend that you engage in both short-term and long-term goals every day if possible, setting some kind of specific things that you can accomplish, and either things that you are moving towards in a mastery sense, or things that you'll feel good about finishing, or things that give you a sense of pleasure. And again, I would recommend that people purposely try to schedule those kinds of activities every day. We know we need to keep social contact. So even if we have to keep physically distant, there are many different ways to keep contact. And as the restrictions lift, of course, we can even engage in others, including physical contact now, to some extent, again, within our 6 feet guidance. We should practice acceptance and gratitude. I was surprised that one of the previous presenters talked about the fact that many people are using meditation, which is, again, not specifically an acceptance-based intervention. But if you do find things that you can be grateful for or can show gratitude for, that would be very useful. Reaching out and doing something for other people. General Dallaire talked about the issue about finding a cause, and I actually put that into my slides already, because I think that that's so appropriate, that if we can find something outside of ourselves, some way to find meaning in this time, that would be very helpful for us. And if in doubt, if you're not sure about what you're doing and what you might do, there are lots of different good pieces of evidence. The Public Health Agency of Canada, Health Canada, the Ministries of Health, the World Health Organization, all provide good evidence-based information about things that you can do to protect and maintain your health during this time. Last thing I'll just mention is that there are many online resources. Again, Mary Bertram talked about the fact that there's been this pivot towards online resources, and this has been truly amazing for me to see, is how mental health services have really made this shift in a light speed kind of a fashion. So many of these are free. Many of them are reasonably easy to access. Again, it does require technology, unfortunately, so it's limited in terms of who it can be given to, but many people can access this in ways that they really couldn't even before. In fact, one of the ongoing crises in mental health in Canada has been access, and one of the things that I think is happening with the COVID-19 pandemic, paradoxically, is that perhaps we're even getting more access to some mental health services in some quarters than in the past. So that's a positive. If you are accessing these services, try to make sure that the resources you're getting are from a reliable or reputation-based organization or provider, so a regulated health provider or a reputable organization. Again, because there's a lot of bad information out there, unfortunately. And if necessary, of course, you can get professional help. Many physicians and health agencies have moved towards distance therapy and distance access. And so again, all of the services that you could have obtained before the pandemic are still available. And in fact, like I say, in some cases, they're even more available. So with that, I'll stop and thank you. And I wish you all the best in coping with this crisis.
Merci beaucoup, Professor Dobson. Thank you very much for being so concrete and so positive in providing some answers and possible ways to deal with the situation, not only the risks, and showing that the situation is indeed rich in risks for mental health, but also that there's an infrastructure of resources that we can tap into. So that is absolutely helpful. Speaking of competence in terms of resources, our next speaker, I think, is also a fantastic resource. I will introduce now Deborah Guinness. She's the president and CEO at the Center for Addiction and Mental Health Foundation. which is one of those great institutions that we can rely on. Deborah has an impressive career, both in the public and the private sector. She was the president and CEO of Catalyst, a global not-for-profit organization that helps build workplaces and work for women. Dans sa carrière, Madame Gillis a constamment travaillé dans les enjeux non seulement de santé mentale, mais d'équité et d'équité en matière de milieu de travail notamment, d'antiracisme et sur les enjeux de droit pour la communauté LGBTQI. She also was a consultant and practice leader with global professional service firms such as PricewaterhouseCoopers and Grant Thornton. In 2016, Gillis was named one of the Canadian Business Magazine's 10 most powerful business people, and she was also awarded the Foreign Policy Association Medal. The year after that, she was appointed to the Canada-United States Council for Advancement of Women Entrepreneurs and Business Leaders. Madame Gillis, the mic is yours. And don't forget, before I disappear, that you can ask, that participants can ask questions on the Q&A function.
I am just going to jump in, Hubert, because it was my understanding, and I did not want to interrupt you during the introduction in case something had changed, that Ms. Gillis was actually not going to be available today, that there had been a change in this panel. So if no one can correct me that this is the case, we would love to hear from her, but I am not sure if we're going to hear from her today. My understanding is she is not going to be available. And I don't hear her, and I see a new message here in my chat, so I'm going to check that out. We are to move on to the question and answer, so I apologize. I didn't want to just jump in there because I know you were doing your thing in terms of the presentation, and hopefully we will hear from her at some point in future. But we will now move to the question and answer period with our two excellent panelists, Keith Dobson and Dr. Mary Barton. So please, Hubert, take it away. Sorry about that.
No, thank you, Tasha, for putting me on the right path. So I will directly go to the questions. And one of the questions that was put in the Q&A had to do with an issue that Professor Dobson raised tangentially, which has to do with whether medication is much of help in dealing with the situations created by the COVID virus, and as opposed to the other options that you very adequately raised, not dealing with medication as a substitute for therapy and cognitive behavior approaches. So maybe that's a question for both of you.
Should I start?
Please.
Okay. So I think it's an excellent question, and I think this goes back to my comment earlier about the importance of looking at individual assessment and figuring out for a person what their personal history is, what the risk factors are that they're dealing with, and what might be the most effective strategy to help them with the problems that they're facing. So, for example, somebody who's had a recent death in the family associated with COVID-19 and is in the grief process probably doesn't need medication to help them through that period of time any more than a person in a grief reaction would otherwise. They probably need support, and they may need some increase in social agency again, coping with the death, but again, medication may not be appropriate. Somebody on the other hand who's been struggling with signs or symptoms of depression for weeks or months may benefit. So again, I think it goes back to the need for an individualized assessment and again, appropriate care. The other thing, I guess, is what does the person themselves wish? What kind of intervention they think that they would benefit from, and also what in the past, if anything, that they've tried before that has been beneficial, and trying to use those resources again that seem to have worked in the past. So those are a few comments.
I just take this more from a policy perspective, building off of what Keith Dobson was saying earlier. One of the things that's most striking about what the policy response has been during the pandemic has been to make online counseling, in some cases phone counseling as well, so not necessarily limited to those who are only able to access the internet, that is the public funding that has gone into making that more accessible to the population is quite historic, really. Whether people are using the services that have become available is another question, but that they are available is very interesting from a policy perspective. And somewhat ironically, it may be access to medication that is a little bit more problematic than it used to be for people who are experiencing mental health issues who could benefit from those medications. Ideally, people would have access to that that individualized assessment and then have the choice of what makes the most sense based on their needs and preferences. But the policy environment has shifted in interesting ways when it comes to both access to medication and access to psychotherapy and counseling.
It's been very interesting to me because I've been involved in the field of cognitive and behavioral therapies, of course, for some time. And we have had some leading international researchers in Canada looking at distance therapies, evidence-based psychological therapies. And we know that distance therapies, either provided through internet platforms or in some cases through smartphones, can certainly have a benefit for many people. One of the risks I do have is that people may sometimes get 1 or 2 sessions of generic support, and they're not really getting treatment, but they may be thinking that they're getting treatment. So again, I think it's important if people are accessing online resources in whatever form, or telephone resources, that they actually get an appropriate dose of an appropriate therapy. But yes, I take your point, Mary, very well. Yeah.
Let me go to another question. There's been a number of comments having to do with particular segments of the population that are vulnerable, particularly newcomers, visible minorities. Mostly of the comments had to do with data and mining the data in order to better understand the particular situations of these segments. But in terms of online treatment and online therapies, are there particular challenges that you face or that you would recommend be addressed in a different fashion for these populations? So both of you also, I think this is a relevant question.
Yeah, go ahead, Mary.
Again, I would take it more from a policy angle. Access, the policy recommendations around providing appropriate care to people from different cultural or ethnic backgrounds or who have different experiences of racialization or different risk factors related to social determinants. The importance of things like providing access in different languages, working collaboratively with community organizations that have strong ties into the communities that are being reached. These are some of and providing policy support to those types of approaches is important. I had one other thing I wanted to flag around this, and I may need to come back to it, so I'll turn it over to you, Keith.
Yeah, no, I would agree with that, what you just said 100% again. I think not everybody has equal access to all resources. And again, when you look at online or distance therapies, they can be delivered by phone, they can be done through webs, they can be done on smartphone technology, they can be provided through various kind of computer applications like one we're on right now. So there are many different ways of delivering these technologies, but not everybody has access to all of those technologies. Not all providers have access to all of those technologies. They're still figuring these things out. It's been interesting in the psychology community that I'm involved in, how many discussions there have been to the therapists in the therapist community about how to deliver distance therapy, sort of the best guidance for how to do that work. So I think everybody is learning about the new technologies and not everybody has equal access. So this is a moving target. So
the other point I wanted to make was more about how therapy is definitely not the only policy response to the mental health impacts of the pandemic. And, you know, again, going back to that population mental health model, what is equally important is attention to social determinants of health and how those are disproportionately distributed across different population groups. And, you know, the things like CERB and providing more income security as a top policy response seem very coherent, and the data on different polls coming out, it's the economic insecurity, it's the people who have lost their jobs who are expressing so much more stress. So providing counseling to someone who's just lost their job rather than trying to figure out how people can be supported to pay rent is certainly a small, important piece, but certainly a small piece of actually supporting the mental health and well-being of someone who is experiencing tremendous stress from factors that are just basic around housing, around employment, around protection from discrimination, and so on and so on.
Yeah, and I would just underscore exactly what you just said, Mary, that we have to look at this both from a social determinants perspective and then at the individual level, again, do idiographic assessments or case-based assessments to figure out what kinds of interventions, if any, might be the most helpful.
So thank you very much to both of you. This is highly practical and optimistic in terms of learning about resources that exist and that sometimes need to be improved, but that are already available. Je vais clore la session maintenant en m'excusant encore une fois d'avoir présenté quelqu'un qui allait être absent. J'espère que les éloges que j'avais chantés à son sujet seront rapportés aux oreilles de Madame Gillis. Mais en attendant, je vais plutôt m'effacer et repasser la parole à Tasha.
Merci Hubert. Et pas de quoi. Dans la pandémie, beaucoup plus de choses sont permis. On fait notre possible. And I think that's part of the message here too, that, you know, to keep our mental health, we have to give ourselves a bit of slack as well. These are uncertain times, and we all have to, you know, realize that it's no time to seek perfection. We have to get along and cope as best we can. I want to thank our panelists for talking about some of those strategies as well, Keith Dobson and Dr. Mary Bartram. I will say my daughter came in while you were presenting, and it was actually very timely, Keith, when you had the list of things: exercise, go outside, all the things I tell her to do. So it's really, I think, great advice. And thank you, Dr. Bartram, for your advice as well. Merci beaucoup à notre panel et merci à tous les panélistes qui ont présenté aujourd'hui. Merci aussi à notre excellente auditoire. Aussi, merci au Conseil des sciences humaines Canada. Thank you again to the Humanities and Social Science Research Council for funding. Thanks for the whole team at the Association for Canadian Studies and the COVID-19 Social Impact Network partners. This is the fourth of our conferences. On veut vous inviter. La prochaine aura lieu le 19 juin. C'est une conférence sur les peuples autochtones et le COVID-19. It will be dealing with Indigenous peoples and COVID-19 and the very serious impacts it is having in those communities. So please check the website for that. June 19th is the date. Thank you so much, everyone, for joining. Stay safe. Merci beaucoup et bonne journée.